Hi, good evening. I'm Dr. Philip McMillan, and today I'm going to continue to do a little bit of inconvenient COVID science. What that means is that I'm asking some hard questions, and I'm doing it on your behalf because it seems as though the scientific community doesn't want to answer these questions. At the moment, I think it's pretty clear that the virus, called COVID virus, is circulating in highly vaccinated regions. Now, what you'll be told is that no, it's circulating everywhere. The whole world is circulating COVID. I disagree. I don't think there is any evidence that COVID is circulating in low vaccinated regions. And from a scientific point of view, I would be very surprised if it was, because natural immunity, mucosal immunity, would prevent reinfections. Not completely, but largely. Now, you have to remember at the beginning of the pandemic, when we started to see deaths in first world countries, the question was what was happening in Africa. Africa had a poor healthcare infrastructure. They should have been decimated by COVID. In fact, they weren't. Now, what was interesting was that when you asked the question, well, what's happening with Africa? The consensus was, well, it's just that they're not reporting the deaths. They must be having loads of deaths and they're not reporting it. They weren't. Why was the scientific community not interested to understand why? So now we have a similar problem where we have this high circulation of virus, and the presumption is that it is occurring everywhere in the world. Based on what I've looked at, based on me asking questions, and please, if you know the answer, if you're in a low vaccination region, please let us know if there is high circulation of COVID. People will then say, well, they're not testing. But they're not testing in first world countries either. They're only doing it when people come into hospital and are unwell. That's how they know. So they're not doing general testing. It's because people are sick why they're being tested. You have to remember that the background to why I asked the question about low vaccinated regions was because of some interesting observations by mining people in Papua New Guinea. It had only 4% vaccination rate. And what they said they can't understand it. COVID is over. How is that possible? So they actually asked the scientific question as to why it wasn't circulating in Papua New Guinea. Of course, it will be because they have natural immunity. I'll explain to you now what it is that is relevant about this and why, or one of the reasons why I think that it is happening. It's very important science because nobody seems to want to answer it. As usual, before I start talking about the science, I want to encourage you to take a look at disease X. So you have to remember that we are promoting this free, well, it's not going to be a free ebook. It is a Kickstarter campaign that we're doing on disease X. And really, we're talking about viral infections. And as part of the gift for you joining in this journey, you sign up for a newsletter and then you can sign up for the Kickstarter, which is separate. We have Capital Conversations, which is just a gift for the people who are interested in learning a little bit more about what was said at that capital discussion. It's important, this capital discussion, because what has happened is that they had experts in the USA all come together and try and share some insights into what they thought was going on with the science. One of the people that is highlighted in this clip, and what we've done is collated the information, is that this is now Professor Harvey Risch. I don't know if I've pronounced that correctly, but he was talking about the origins of COVID and that it had leaked from the Wuhan Institute of Virology in 2019 and characteristics about it. Now these are condensed pieces of information from a very long conference that happened. And so we've taken the full length discussions and condensed it into very short, easy, simple things for you to read and hopefully be able to challenge people when they're telling you that you don't know what you're talking about. That's usually the problem. They don't have the you don't have the science at your fingertips. So please, if you're interested in that, click on the link below and join us in this journey. Um, the Other thing I'll mention at the end with regards to the Kickstarter, and I'll show you the work in terms of the ebook that we have done. So let's get back to the question of the science. Now, this is an important question in terms of why is it that COVID continues to circulate so highly in vaccinated regions? What is it that is going on? And so we have a situation here where it seems that the immune system is not working in the normal way. And so this is a paper that was done in November 2023. And I keep making reference to it because the principles that it highlights are going to be relevant today. And this paper showed they were looking at neutralization escape by the SARS-CoV-2 Omicron subvariant BA2.86. You have to remember that this variant is the father of JN1, or the grandfather of all of the variants that we're dealing with now. So this was the first one that broke out of the pattern, and almost all the variants that are coming along are on the origin of this BA2.86. And so they did an important piece of research on that to try and look at what was happening when they looked at the vaccinated response in terms of antibodies. So I'm going to take you through this because this is what I think is part of the problem. One part is IgG4, which I don't have time to talk about in any detail. But this time, I'm just focused on antibody response. Now, a proportion of the antibody response is going to be IgG4, which is a tolerant antibody. So that's another layer of complication on it. But just in terms of what happens after the boosting with regards to the vaccinated cohort, what really is happening with their antibody levels. So, going back to the paper here, what we have is that we have here an image showing this is what happened with regards to the bivalent booster. But before, let's go to the no bivalent booster. So this was the baseline time frame. And what you have to look at is that at baseline, this is they didn't get a booster. This was more than I think 6 months. Their antibody count was 6,000 to the Wuhan variant. To the BA 2.86, it was 138. This was the bivalent no booster. So they already been vaccinated and they didn't get boosted. At 6 months, if you slide it along, you have here that no infection. You can see here there's still the highest antibody level is still to the original Wuhan variant. Okay? To the Omicron variants, it's pretty low. And you can see here that even if they then had an infection, look at the response. Even with an infection at 6 months, the primary antibody response went from 6,000 to 20,000 to the Wuhan variant. It went from 138 to 434 to the BA2.86. So you can see that the primary immune antibody being produced, for which a big proportion of this will be IgG4, is locked into the original variant of the virus. And when you do the same principle, when you go across, and then even if there was no bivalent booster here, if they had the bivalent booster, so now this cohort has been boosted. What then happens is that, again, the highest antibody response is 16,000 to the original variant. Look what happens to BA2.86. It only goes up to 300 from 138. So this is the point I'm making, is that this is the primary immune response. If they had no infection and they were boosted, what you then see as you slide along here is that I'll get both of them in. At month 6 with no infection, it's still at 10,000. So it came down from 16,000 to 10,000. This is still the low at 197. No infection. If they had an infection, you can then see here that after they had been boosted, it goes up to 35,000. This goes up to 979. So, whichever way you're taking it, the primary immune response is to the original variant. Now, some people may say this is no problem. Why are you producing antibodies to a variant that no longer exists? Is it logical? Is it good? To me, that just spells a problem. That is a real problem. Now, they would say now that this is what is also happening to the unvaccinated. I'm telling you, this is not happening to the unvaccinated. It's not that they can't get infected, but they're not getting infected over and over again unless they have interferon autoantibodies. And if you are unvaccinated and you're getting infection after infection, fix your gut. That's a different conversation. But the point is that we are seeing circulation still in high vaccination regions. Now, let me explain how the immune system works with natural immunity. I don't have the paper to show you. Pity I didn't pull that up. But what was so fascinating when they looked at the natural immune response, only a small proportion of it was targeting the spike protein. It was targeting the nucleotide protein, the M protein. It was targeting ORF proteins. And what that suggested is that the main immune response was not so much an antibody response, but a T cell response. That means that because the ORF proteins are inside the virus, they're not on the outside. So what would happen is that when the virus then opens up, almost releases the proteins and the RNA, and it starts to make these proteins, the cell would put a flag up on the outside saying, I am making a strange protein. It would then get killed by the immune system. That's how T cell immunity works, different from antibodies. So the primary immune response, it suggests, in the unvaccinated cohort is a T cell response, not so much an antibody B cell. That's supplementary, but it doesn't seem to be the primary thing. So I've put together what I think is an analogy. You can tell me if this works. And I'm trying to see if I can get the idea across. Because the immune system is so hyper focused on the original variant, just to remind you what it looks like, you can see here, this is after vaccination, 6 months, it's 35,000 still focused on the original variant. Current variant is higher, but not as high. So let me give you what I think is my analogy. If you imagine that the immune system is the border control and they are checking to see if they can identify a problem person coming from a plane, say they're looking for a terrorist. And it just so happens that this terrorist is a woman and they've been told that she's wearing a red jacket. So the border patrol are looking for someone with a red jacket. If the woman comes through and she's changed her jacket, ties up her hair, puts on trousers, suddenly they don't see her because they are looking for somebody with a red jacket. And so this is how I tend to see it, is that in the this is the original Wuhan virus. On the left is the lady in orange, and on the right is the Omicron variant. But the immune system in the vaccinated has been primed to look for an orange person. She needs to have orange hair, orange top. That's who we're looking for. So if she comes through with purple hair and a purplish blue top, they let her through. And that's because they are so focused. They're not noticing that she is Caucasian, she's a woman, she's, say, 5'6", she walks in a particular way. This is what is missing in terms of the immune system. That's my analogy. I don't know if it's the best analogy, but it is what I'm trying to highlight, that when you have an immune system that is hyper focused on one particular thing, and in this case, it's variants of the spike protein, you're unlikely to have a robust response. That's one of the reasons why we're seeing reinfection after reinfection after reinfection. It's inconvenient And I think people are hoping it will just go away, but it can't. The immune system is now so focused on this. And you can see based on the data, even giving an updated booster, it still is focused on the original variant. It's just hyper focused. Now, again, people may say, well, there's no big deal. Omicron is mild. You know, let's just move on from it. Well, I got some statistics for you. And this is just to help you know, for those people who are interested in the science, this is what is going on. Now, I'm taking the UK statistics, but I suspect this will be similar wherever you go in the Western world. So I'm looking at accident and emergencies attendances and emergency admissions. This is for July 2024. And so what you can see here, total attendances has gone up by 5.5% from July 2023. Remember, lots of people have died, so excess deaths are up. Everything should be lower. Type 1 A&E departments are 3.3% higher. Type 3, which are low, 9.1% higher. People are just sick and they don't know why. Following down, emergency admissions increase of 3.3% compared to July 2023. Emergency admission growth over the last 3 months compared to the same period last year was 4.3%. And over the last 12 months compared to the preceding 12 months was 6.8%. We are in summer and at a point where I keep on saying we shouldn't be seeing high admissions and pressure on the system. Remember, we've just been through 4 years of a pandemic. A lot of people died. So, why are so many people sick? Why are excess deaths not coming down? Now, just to give you another insight into this, and this is important because a lot of people don't understand the nuances of the data. So, I'll try and explain this to you. So, I've highlighted here there were 129 334-hour delays from decision to admit to admission this month. That's in July 24. The average in July 2023 was 3,492, while in July 2024 it increased to 4,172. That's a 19.5% increase. Now, this is important because the delay, what again, if you don't understand what's going on, the 4-hour delay indicates that there is pressure on the hospital system because there's only a 4-hour delay because they don't have a bed. And so, therefore, because they don't have a bed, the decision is made that this person needs to be admitted. There are no beds available. And so that's why you then have a 4-hour delay. So it indicates that the hospital is full in the middle of summer. That's a very significant pattern. And if you go further in terms of this here, it highlights even more. Right down here, of these 4-hour delays, of the 36,000 were delayed over 12 hours in accident and emergency from decision to admit to admission. That equates to 1,187 decision to admit delays over 12 hours per day, an increase of 57% from July 2023. This is what it looks like in winter when the system is under pressure. This is summer 2024. And what I'm saying to people is that you can ignore this as long as you want. The science tells us this is going to be a nightmare winter. We've just had a super spreading event happening all across the Western world in the summer. What's going to happen when all these people continue to be sick? You have to remember that what increases mortality in hospitals is not just if somebody dies of COVID. It's when you have a very sick person who you can't get into the appropriate bed. They're sick, you can't get them into the hospital, into the right place, they die. The complications will increase for every single aspect of medicine, whether it's medical, whether it's surgical, every emergency. You can't get into A&E because A&E is full of patients. Wait, I'm telling you, this is just a nightmare scenario. Sitting on it and just hoping it goes away is certainly not a scientific way to approach this. The reality is that what we have got is a situation where we're getting repeated infections. And remember, every blow is like a punch with regards to the SARS-CoV-2. It makes you sicker and sicker and sicker. We need to find answers quickly. This is very, very important. So this is why we're developing Disease X. I'm going to play you a very short clip to encourage you to sign up in the description below. Watch this here. So the point is, because nobody is telling you what's going on, I am just saying, based on the science, we have a problem. If we continue to ignore the problem, it doesn't mean that it's going away. It just means we have less opportunity to mitigate it. Everybody needs to now be wise, because one thing is for certain: if they really were interested in your health, they would be willing to be wrong to protect it. At the moment, everybody's protecting themselves. They don't want to say anything because they don't want to be wrong. That is not the way to take care of patients. Very challenging times ahead, and sadly, it seems that the responsibility is falling to each and everybody to find answers for themselves. We can only ask you to join us in our research journey. Click on the link below. I'll try and share as much as I can. Have a great evening.